All right, I'm going to kick it off. So today we're talking about pediatric hypermobility, so hypermobility in kids. A lot of this will be repeated from previous stuff, but I've just included it all so it's all together. But for those of you who don't know me, I'm Steph. I am an osteopath here at North Canberra Osteopathy. I work exclusively with hypermobile adults and I work with all kids. I started in this hypermobility stuff because I have lived experience. So I've now been diagnosed with hypermobile Ehlers-Danlos, POTS, MCAS, autism, ADHD, endometriosis, adenomyosis, and PCOS, which is part of why I'm so passionate about teaching everyone about all of the things that can come with hypermobility, because there are so many and I'd like to stop collecting them all. I am therefore extremely passionate about all things hypermobility. I also love reading, especially romantasy books and watching anime, and dog mum to Angus and cat mum to Piper, who is not pictured, and Angus is walking away. All right, so hypermobility in kids. So in 2023, the Ehlers-Danlos Society released a specific diagnostic framework for pediatric joint hypermobility, and this was developed due to the challenges presented when trying to diagnose children and adolescents using the 2017 HEADS criteria, as that was developed for adults. This criteria is designed to assess children from 5 years old through to biological maturity. And that means that it's the completion of puberty or bone growth, or when they are 18, whichever happens first. So it's the age of 5 and up specifically because children are already hypermobile, and so we have to take that into account. Most of their bones and things are formed by the age of 5, so then we're able to properly assess joint hypermobility from there. There are other things that we can kind of pick up, but there's nothing definitive until 5. So the first criteria is generalized joint hypermobility, and so this uses the Baton score. So in the HEADS versus HSD thing that I did previously, we went through all of these as well. The difference here is that in children, before they've finished puberty, the score has to be 6 or above, whereas in adults it was 5 and above. So the score is given out of 9 points. We'll go through those again. So we start with the pinky fingers. So resting palm of your hand flat on a flat surface with the palm side down and fingers out straight. It's if the fifth finger can be bent backwards beyond 90 degrees. So it has to get to at least 90 degrees. And if yes, you get 1 point on each side. Then we have thumbs. So with the arm out straight and palm facing down, the wrist is then fully bent downward, and can the thumb be pushed back to touch the forearm? And that's yes, 1 point on each side. Then we have elbows. So with arms outstretched and palms facing to the roof, does the elbow extend beyond 10 degrees backwards? And that's again 1 point on each side. And then the same thing for knees. So if standing up with knees locked back, are the knees extended beyond 10 degrees backwards? And if yes, 1 on each side. And then finally, we've got the spine. So can you bend forward and place the palms of your hands flat on the floor without bending your knees? And that's just 1 point there. So if they score 6 out of 9, then that's met for that criteria. But then we also have the next criteria is musculoskeletal complications. So joint hypermobility is sometimes associated with issues and injuries of the joints and soft tissues, as many of us will know. And a child is considered to have musculoskeletal complications if they meet 2 of the following 3 criteria. So first one is episodic activity-related pain that is not chronic in frequency or duration. So this means pain that is brought on by activity. So if they're playing sports or running around doing anything generally active, and that causes pain, but not every time. So that's what the chronic pain duration is defined as pain that persists or reoccurs for longer than 3 months. And then frequency was really hard to find a definition for, but elsewhere it is defined as pain that is experienced on most days, so like 4 or more days a week. And then we have joint instability is the next one. So we've got recurrent joint dislocations. So recurrent just means repeatedly. complete displacement of the joint. So shoulders, kneecaps are usually the most common ones. You can have fingers and wrists and things as well. Anything can dislocate, but it's much harder to do it in other places. Shoulders and kneecaps are very common. We've then got recurrent joint subluxations in the absence of trauma. So that many of us will have experienced before, if you're hypermobile yourself, is a partial or incomplete displacement of the joint. And so that's kind of where it might wobble and it just feels a bit funny, or it might have wobbled and then it just gets really sore afterwards. And then we've got or frank subluxation on physical exam in more than one joint. So if I was testing someone's kneecaps and was able to completely displace them basically off the knee, which I do see quite a bit, that's classified as frank joint instability, which in that joint, and if we've got that in more than two joints, then that counts for this criteria as well. The other definition too, so dislocations often need to be set by a health professional, although many hypermobile people may set it themselves. And I would just point out that that is highly discouraged due to the risk of neurovascular damage. So you could have nerve or blood vessel damage because of putting it in the different way than it came out. And subluxations can vary from small to large. So the most commonly affected joints, so knee, especially patella, ankle, shoulder, hand, and wrist were the ones listed in the study that they used to make this criteria from. And then we've got soft tissue injuries. So soft tissue injuries, so either one major one needing a surgical repair, such as a hamstring tear or a complete rupture of a ligament, and or multiple current minor tendon and or ligament tears. This was really hard to pin down exactly what they meant, because it then said, like, you should have it on an image. And I'm like, well, if I have someone coming to me with an ankle sprain, I'm not going to go and send them for imaging. I know what it is. But it said you need to have multiple. So, and then when I was diving into a bit more, the criteria on this is much stricter than in adults due to the normally increased prevalence of soft tissue injuries in children. So it needs to make sure that there are, it's a higher bar that they need to cross to get that one.
Multiples, like lots of places, not just
Yeah, multiple places. Yeah. But my brain is like, well, you could have sprained two ligaments in your ankle when you rolled it, and that would count as two different spots, but I'm not going to know that without imaging. So it's really tricky, that one, actually. But I've found most that fall in this category meet the first two anyway. Then we've got comorbidities. So comorbidities are other health conditions that sometimes occur alongside joint hypermobility and can further impact quality of life. So a child is considered to have comorbidities if they are distressed or disabled by any of the following. So I'm going to go through all of these in detail and what they mean, but we've got chronic primary pain, chronic fatigue, functional gastrointestinal disorders, functional bladder disorders, primary dysautonomia, and anxiety. So chronic primary pain is chronic pain that is in one or more anatomical regions that is characterized by significant emotional distress, including anxiety, anger, frustration, or depressed mood, or functional disability, so interference with daily activities or reducing their participation in social roles. So the kind of pain that might stop them from wanting to play games and things with their friends or go climbing on things. That's what we're looking at there. Then we've got chronic fatigue. So bear with me because this one is huge. We are going to go through chronic fatigue properly with Tanya in February when they come and do a presentation specifically about chronic fatigue syndrome. But the diagnostic criteria is the same and it's a lot. So bear with me. So there's 3 required symptoms, and then you have to have one of 2 other symptoms, which I'll go through on the next slide. But so the first of the 3 symptoms, so we've got a substantial reduction or impairment in ability to engage in pre-illness levels of activity. And that's because usually chronic fatigue is triggered by often EBV, or like COVID has triggered it for a lot of people. Some sort of viral infection is most commonly what will set off the reaction for people to then develop into chronic fatigue syndrome, or myalgic encephalitis. And yeah, I can never remember. Thank you. I always say encephalitis and then second guess myself. But yes, myalgic encephalitis or chronic fatigue syndrome. So you may also hear it referred to as ME/CFS. So the significant reduction or impairment in the ability to engage in that pre-illness level of activities. So that includes at work or at school, in their social life or personal life. Obviously, that's more with older kids than it is with younger kids. It's mainly just school and play kind of things. That lasts for more than 6 months and is often accompanied by fatigue that is profound, a new onset, so hasn't been around their whole life, not the result of ongoing or unusual exertion, excessive exertion, and not substantially alleviated by rest. So, yeah, those are pretty self-explanatory. Then we've got post-exertional malaise. So worsening of symptoms after physical, mental, or emotional exertion that would not have caused a problem before they got sick initially. So PEM is what it's referred to as, often puts patients into relapse that may last days, weeks, or even longer. Some patients have sensory overload that can sensory overload can induce that post-exertional malaise, and symptoms typically get worse 12 to 48 hours after the activity or exposure and can last days or even weeks. And then finally, we need to have unrefreshing sleep. So patients with ME/CFS may not feel better or less tired after a full night's sleep. This may occur despite the absence of any specific objective sleep alterations. So even if you change it, it doesn't make much difference to that sleep, and not feeling refreshed afterwards or feeling rested. You can see here we've got two little asterisks. So the asterisks indicate, so the frequency and severity of those symptoms need to be evaluated, and the committee that formed this criteria specified that for diagnosis, patients should have symptoms with at least half of the time with moderate, substantial, or severe intensity. So they have to be pretty extreme sort of levels. And then we've got these two additional symptoms, so you need at least one of. So we've got cognitive impairment, which again, that severity and frequency needs to be assessed in a diagnostic criteria by a doctor. And then, so that means we've got problems with thinking, memory, executive function, and information processing. They may also have attention deficit and impaired psychomotor functions. So just basically brain fog is the fancy version of brain fog. All of that can be exacerbated by exertion, effort, standing upright for too long, stress, or time pressure, basically anything that stresses the body. And this may have serious consequences on the patient's ability to maintain a job or attend school full time. So a lot of the time it will be impacting grades or impacting attendance at school for these kids as well. And then we've got orthostatic intolerance. So a worsening of symptoms upon assuming or maintaining an upright posture, so sitting up in bed or standing up from sitting down. All of these are stuff we talked about in the POTS lecture as well, but I'm just going to refresh everyone's memory so it's all together. So this is measured with heart rate and blood pressure abnormalities during standing. I don't know what bedside orthostatic vital signs means, but head up tilt testing is the other one as well. And so symptoms include lightheadedness, fainting, increased fatigue, cognitive worsening, so worse brain fog, headaches, or nausea that are worsened when upright. So symptoms are usually also then improved by lying down. And it says improved specifically, but not necessarily resolved. So orthostatic intolerance is often the most bothersome manifestation of ME/CFS among adolescents in particular. And that will be the one that usually causes the most problems with school attendance as well. Then we've got functional gastrointestinal disorders. So this includes constipation, diarrhea, recurrent abdominal pain, reflux, nausea, and vomiting. Now, I just wanted to list these because there's very specific criteria about whether or not it meets the diagnostic thing that it needs to meet for this criteria. And that's like a whole long web page, but it's the Rome criteria if anyone's interested in looking that up. And then we've got functional bladder disorders. So any problems with urinary incontinence could count here. So because the children being assessed in this criteria are over the age of 5, wetting either during the day or at night should be infrequent. So if there is concern there, then we want to look at this as well. We've got primary dysautonomia. So dysautonomia is what we were talking about with POTS as well. That happens when there is a problem with the autonomic nervous system, which controls involuntary functions such as breathing, heartbeat, and blood pressure without you normally having to think about it. So primary means that this is its own issue and it's not linked to another cause. Sometimes this can happen due to medications or like viral infections and stuff. Most of us, even without POTS and things, have had when you get sick and then you stand up, you feel a bit dizzy, that sort of thing. But this is specific to its own unique thing. And so for more information about that, check out the POTS lecture that I did previously, because I went into detail explaining all of that in much more deeper detail. Then we've got anxiety. So this is the DSM-5 criteria for generalized anxiety disorder. Excessive anxiety or worry occurring more days than not for more than or equal to 6 months about a number of events or activities, and I specified like stressing about work or school or things like that, friend groups, social anxieties and things like that all count in there. And the person often finds it difficult to control the worry. So even if they're conscious of it, they're still really struggling with it. The anxiety and worry are associated with 3 or more of the following. So at least one has to be present on more days than not over the last 6 months. So restlessness or feeling keyed up or on edge, being easily fatigued, which we'll notice there's a lot of overlap with a lot of these, difficulty concentrating or mind going blank, irritability, muscle tension, and sleep disturbance. So that's difficulty falling or staying asleep, or restless, unsatisfying sleep. So again, another link. The anxiety, worry, or physical symptoms cause clinically significant distress or impairment in school, occupational, or other important areas of functioning. And the disturbance is not attributable to the physiological effects of a substance or another medical condition. And the disturbance is not better explained by another mental disorder. So these are the kind of things that we need to be screened by a GP or a psychologist. So then we've got the skin and tissue involvement is the last major criteria for kids. So in some people with joint hypermobility, there are unusual skin symptoms and characteristics. Skin involvement occurs when 3 or more of the following, I think there's 5 symptoms are present. And these are, again, directly taken from the HEDS versus HSD lecture that I did, but we'll go through them again. So it's unusually soft or velvety skin is a really hard one to quantify. But basically, I mean, the way that I know is that everyone used to come up and stroke me and tell me my skin was really soft. And that was really weird. But it turns out that didn't happen to everyone. And there was a reason for it. So, and weirdly enough, that is a pretty universal experience if you've got the really soft skin. Unless you're autistic and didn't let people touch you, then that might not be the case. So then we've also got mild skin hyperextensibility. So the skin has the ability to stretch beyond its normal range. And this is most accurately tested on the hairless underside of your forearm and gently pull until resistance is met. And if that skin stretches beyond 1.5 centimeters, then it is considered hyperextensible. So this is the kind of weird things that it looks like. And I haven't done it in advance this time and bruised myself like I did last time, but I will probably have bruises now from that. We've got unexplained stretch marks. So this is a really big one, especially for the kids, because they shouldn't really have them yet, especially if they're quite young, haven't done any big growth spurts yet. If there is any kind of stretch marks, then this ticks straight away. But the unexplained striae densae, which is the fancy, or rubae, which are the fancy names for stretch marks, at the back, groin, breasts, thighs, and or abdomen in adolescents, men, or prepubertal women without a significant history of gain or loss of body fat and weight. This is a really confounding feature of this in criteria because it makes it really hard to quantify what's a significant history of weight gain or weight loss. My doctor was very happy with mine because I found them on the back of my knees. So that's a very weird place to have them. And I didn't even know they were there. So a lot of the times you will be dismissed for ones on the abdomen or thigh as an adult, but if they have them as kids, especially without any sort of weight issues, they will classify that, and then we get into the grey area of weight issues, and I get mad about that as well. But those are the kind of things that they will dismiss because of they'll dismiss the stretch marks if that's there. We've got pyogenic papules, so bilateral pyogenic papules of the heel. So pyogenic papules are small bumps of fat that appear under the skin when pressure is applied to the wrists or heels. So this is obviously specific to the heels for this criteria. What I didn't realize when I did the first lecture is that you have to be standing up. So socks off, standing up, and then if you get those, because I didn't realize I had them until I was assessed by the doctor and she went to stand up and I went, oh, I didn't know. So if you stand up, you usually have to get someone else to look at your heels. And if you've got these little bumps, and they're usually like painless, they don't cause any issue, but it can in some people be a bit tender as well. And so noting that bilateral means that they have to be on both of your feet to meet that criteria. We've also got abdominal hernias, so recurrent or multiple abdominal hernias. So a hernia occurs when an internal body part pushes through a weak spot in the tissues that support it. So this creates an outward bulge, typically in the abdomen or the groin. And so multiple means that we have to have hernias that have occurred the same place multiple times, or we've got, multiple means different locations. So it can occur once here or once here, or recurrent means repeated hernias in the same spot. Then we've got atrophic scarring. So this is one of the ones that is really tricky to pick up and it's really tricky to pin down because a lot of us don't have scars big enough to see what this looks like. And it's quite often, even when you've got little ones that do it, my doctor told me it was too small to quantify if it was atrophic or not, which is a bit silly. But atrophic scarring involving at least 2 sites and without the formation of truly paresis, I can't remember how to say that word, or hemosideral scars, as seen in classical EDS. I'll show you those in a second. But atrophic scars are sunken or depressed scars that form when the wound heals below this normal layer of the skin, where the normal surface layer of the skin would be. So this happens when the body does not produce enough collagen during the healing. So those of us that have any idea about it, so collagen being defective is part of why we have hypermobility. So that then translates to the skin and the scarring being different as well. So we've got the paresis scars that are atrophic scars that have widened and become paper thin, and they are often referred to as cigarette paper scars, as they look like the crumpled, very thin paper that people roll cigarettes with. And we've also got hemosideral scars, which develop when blood breaks under the skin, leaving brownish discoloration due to the iron deposits, but basically the same texture, but these ones just have blood in them as well. So a final thing that we have to do for kids with this criteria is exclude other conditions. So hypermobility spectrum disorders can only be diagnosed when all other possible explanations for the person's symptoms have been ruled out. So this includes the genetically defined types of Ehlers-Danlos syndrome, other connective tissue disorders, syndromic conditions, chromosomal microdeletions, skeletal dysplasia, and neuromuscular disorders. So basically that all comes together in this little pediatric diagnostic flowchart, which I will post with this link because that is really hard to read, but yes, it will let me zoom in. Search. So is starting at the top. So it's a bit of a flow chart to get the diagnosis right, because there are a bunch of, basically you get labeled about which bits you meet and which ones you don't. So essentially, does the child have generalized joint hypermobility? So do they have a 6 or above out of 9 on the Baton score? If they don't, then they are not hypermobile. So we don't have to worry. Well, not hypermobile based on the Baton score, but that's an argument for another day. So if they meet that criteria, then they have the generalized joint hypermobility. Do they have the musculoskeletal complications? So that was the episodic activity related pain, the frank joint instability, and the soft tissue injuries. So if that's a yes, then we come down here. But if not, does the person have other comorbidities? Yes or no, and basically do they have skin or tissue involvement? So basically if they have none of these things, then they just have pediatric generalized joint hypermobility. So then that can classify whether they have with skin involvement, with comorbidities, or with both. And then if they did have the musculoskeletal complications, then we come all the way down here again. That is then classified as pediatric generalized hypermobility spectrum disorder, musculoskeletal subtype, if they don't have any comorbidities or skin and tissue involvement. And then again, we've got musculoskeletal subtype with skin involvement. And then we've got the systemic subtype, which is basically, yes, you've got all of the things, but not the skin and tissue involvement. And then you've got systemic subtype with skin involvement. So it's there's like 8 different diagnoses that we can get from there. But basically it's just telling the physicians that are then going to see that diagnosis, which kind of issues that child may have related to their hypermobility as well. And that's all. You can see my very many references. If anyone wants them, let me know. All right. I'm very proud of myself for remembering to record, and now I'm going to stop recording.